Good morning, students. We're going to cover fractures today. So fractures involve some sort of break in the continuity of the structure of the bone, usually from some sort of traumatic event. It can also be secondary to disease processes such as cancer or osteoporosis. There's different classifications for fractures. This includes an open fracture where the bone has actually it's exposed and it's broken through the skin. So the skin's broken and the bone is exposed. With this closed fracture, the skin remains intact. And then there's complete fractures where the break goes completely through the bone, or maybe an incomplete where it's just a partial break. So here's a picture of an open fracture versus a closed fracture. With open, you can see how the bone is exposed. Also different types of classifications: transverse, spiral, green stick, these are common in children, communid, oblique, pathologic, and stress fractures. There's also displaced versus non-displaced. With displaced, the two ends of the bone are separated from one another. With non-displaced, the bone is still aligned. And non-displaced is more common in transverse, spiral, and green stick. So just kind of know the difference between displaced versus non-displaced. Manifestations associated with fractures include edema, localized swelling, pain, tenderness, muscle spasm, deformity, loss of function, guarding. So pretty common manifestations based on what we would expect with a fracture. Factors that influence healing for a fracture include displacement in the site of the fracture. So some fractures, like if you break a little toe or something like that, areas that don't get as great of blood supply might not heal as quickly as other areas. Immobilization, the use of internal fixation devices, which we'll talk more about in a minute. Infection, poor nutrition, we know we have to have adequate nutrition for proper wound healing. Age, and smoking status. There's several complications of fractures to consider. This includes delayed union, non-union, malunion, meaning there's some sort of malalignment with the bone. Angulation, pseudoarthrosis, refracture, and myositis. For fracture reduction, so this is getting into our treatment and management of fractures. Closed reduction, this is non-surgical manual realignment of the bone fragments. Sometimes we need traction or counter traction applied to help stabilize the bone. Usually this will be performed under some sort of anesthesia, because you can imagine it would be very painful to realign a fracture. And then afterwards, we're going to apply some sort of immobilization, whether this be traction, fracture, splint, brace, and your textbook goes into more details here. Open reduction, this involves surgery. So closed reduction is just like a manual realignment. Open reduction, we actually have surgery. And to stabilize the fracture, we will use wires, screws, pins, plates, rods, etc. Now, since this is a surgical procedure, there is risk for infection, and then we want to consider all of our post-op complications, ambulate your patients early, get them moving, because we know there's so many risks associated with immobility. Traction, this is a pulling force applied to the injured body part or extremity. And the purpose of this, like I mentioned earlier, this might be done for patients that have closed reduction. It helps to reduce pain and muscle spasms and also immobilize that injured part of the body. And it can reduce the fracture, dislocation, even treat a pathologic joint condition. So Buck's traction is a common form of traction that we see used. And then there's more complex forms of traction, such as skeletal traction. You can see how this is much more complex. So just know what traction is and when it's appropriate to be used. For immobilization of fractures, we want to use CAST. This allows patients to still perform many of their ADLs while maintaining immobilization of that fracture site. And it allows for the fracture to realign and heal properly. The two most common materials used for CAST are plaster and fiberglass. External fixation, this is another type of procedure or intervention used for healing of fractures, and it's going to involve metal pins, wires that are externally attached. It applies traction, and it's used for very complex fractures with extensive soft tissue damage, and it attempts to kind of save that extremity that might have otherwise required amputation. So this is a picture of external fixation. You can see how we have rods and pins to stabilize the fracture site, but it's all external. And again, this is for very complex fractures. Internal fixation is essentially the same concept, it's just internally. So rods, pins, screws, but internal. And you can see here we have a picture of an X-ray with external fixation devices. For nursing assessment, you want to assess how the traumatic episode occurred and then get our usual subjective data. Moving on to objective data, collect our usual objective data, and then a focused neurovascular assessment. So muscular injuries that can alter the neurovascular status of an extremity. Assess and document before and after treatment. So, pulses, their feeling, sensation, and always compare this bilaterally. Other components of a neurovascular assessment include color, temperature, cap refill, pulses, edema. So your neurovascular assessment is so important when caring for the patient with an acute fracture. Also motor function and sensory function is going to be very important. So I'll kind of let you read through this for a second. Good. For our patients that do have a cast post-fracture, again, frequent neurovascular assessments. We want to make sure that cast isn't too tight or compromising neurovascular status. Teach your patients to apply ice for the first 24 hours. Elevate the extremity above the heart for the first 48 hours. Both of these interventions are going to help reduce pain and inflammation. Exercise the joints above and below the cast. So range of motion exercises are helpful here. Cast can be pretty itchy. We don't want our patients shoving a pencil down there to itch. Instead, use a hair dryer on the cool setting to help relieve the itching. But if they're shoving things down into the cast, that could possibly cause compromise in the skin integrity and lead to a wound, and then we're not going to know that a wound's there because it's covered by the cast, and it can become infected very, very quickly. And then we really don't want our patients getting the cast wet. Usually they'll need to cover it somehow prior to getting it wet or showering. If they do get it wet, dry it thoroughly afterwards. They do need to report any kind of increase in pain. So if they're doing their eyes and taking their pain meds, but their pain's getting worse, that would be a red flag. We could worry possibly about maybe compartment syndrome, which we'll talk more about in a second. Report any kind of swelling, burning or sores, even like a foul odor under the cast. We do not want them to elevate the extremity if we are suspecting compartment syndrome, because that's going to further reduce blood supply. Don't get a plaster cast wet. Don't remove any padding from inside the cast. Certainly don't insert objects. Don't bear weight for 48 hours. And don't cover the cast with plastic for a prolonged period of time. Complications of fractures. So this includes infection, malunion, non-union, avascular necrosis, compartment syndrome. Again, we're going to talk more about this in a second. Thrombosis, fat embolism. This is especially common with breaks in large bones such as femurs, rhabdo, and hypovolemic shock. And your book goes into more detail on each of these. So compartment syndrome, this is very important. It involves swelling and increased pressure within a limited space, so a muscle compartment. And it compromises the neurovascular function of the tissues within that muscular compartment. So there's 38 different compartments within the upper and lower extremities, and compartment syndrome is associated with fractures with extensive tissue damage, such as a crush injury. Most commonly, the sites that this will occur is like distal humerus, proximal tibia. It can even occur after surgery. So to assess for compartment syndrome, you're going to consider the 6 P's: pain, pressure, paresthesia, pallor, paralysis, and pulselessness. Any of these, major red flag, especially if you have pain that's not managed by like opioids or, our normal pain interventions. And if they start having like numbness or tingling in their extremities, if it's getting pale, major red flag for compartment syndrome. Obviously, paralysis and pulselessness are going to be very late findings associated with compartment syndrome. If we suspect compartment syndrome, we are not going to elevate the extremity because this can reduce blood supply. And do not apply ice or cold compresses. Again, it's going to cause vasoconstriction and further reduce circulation. So elevation and ice are good for normal fractures, not good if you suspect compartment syndrome. The only treatment is to relieve the pressure for compartment syndrome, and this usually involves surgical decompression. Late stage, it might progress to amputation. So here you can see there's an extremity that suffered from compartment syndrome and had to go in and have a surgical decompression to allow for tissue expansion to relieve the pressure. Fat embolism, this is another complication associated with fractures. So you have fat globulins inside your bones, where your bone marrow is. And again, these are more common with fractures of long bones, ribs, tibia, pelvis, but it's essentially the same concept as a venous embolism, in that it causes occlusion of a vessel. And we will pick up in a different video to cover amputation.